am Dr. Amy Rule, and we didn't have enough time to really give a lot of our participants a chance to participate in land acknowledgement, although I think many of our participants are probably from Utah, but I was going to model this and then we'll dive right in. So I'm in Cincinnati, Ohio, and I want to acknowledge the Shawnee and the Miami people who originally inhabited the land where my home is and where I work. I acknowledge the pain and the genocide that they experienced and honor them today in hope of working together towards action, healing, and hope. If I can make this work, there we go. Welcome to GHEARD, Global Health Education for Equity, Antiracism, and Decolonization. As I said, I'm Amy Rule, and I'm from Cincinnati Children. And then my co-lead and co-presenter tonight is Heather Huck from the Baylor College of Medicine, and we'll do our more formal introductions in a minute. We have no disclosures. This curriculum is under development, so we ask that you don't share any of our materials at this time. Tonight, our goal is to talk a little bit about how we have developed GHEARD, and then to get to pilot some activities for the new curriculum, and we would love your feedback. Much of the spirit of GHEARD is learning how our stories impact our global health, underserved, and rural work. And so in light of that, I am going to start a little bit with my story. So I am a white and American disabled woman who grew up as a military brat in the DC suburbs. I grew up with a rare skeletal dysplasia and spent a lot of time in children's hospitals, and that was actually what originally inspired me to become a pediatrician and a child advocate. I was privileged to travel for care to a center with one of the largest skeletal dysplasia clinics in the US, and I met kids from all over North America and all over the world in the waiting room. We shared many of the same disability and patient experiences, but very few other experiences. And it was in those experiences that I really got interested in medicine, in disability rights, and became really more aware of how differently my life might have been if I had been born somewhere else. As a college and medical student, I spent 5 summers in Eastern Europe working with nonprofits that were working to do institutionalized children with disabilities. And it was not uncommon when I was living in Romania, when I would be walking to work, that because of my disability, I would be mistaken for a beggar and offered money, and I would have to awkwardly explain to people that I was an American medical student. In contrast, when I was a resident and hospital medicine fellow in East Africa, I was often given many unearned privileges as a white North American pediatrician. And it was in those contrasting experiences and processing all of this after my fellowship that I really became interested in global health ethics. And I shared a conversation several years ago with Dr. Huck.
Hi, everybody. My name is Dr. Heather Huck. I'm medicine. For my introduction, I am a presenting cisgender heterosexual woman with multiracial roots, both Pakistani and white. And I also like to say that I'm a second generation global health physician. The woman on the right-hand photo is my mother, who is a family doctor who spent time in the 1980s in Uganda working as a village health doctor in a village outside of Kampala. And she was crazy enough to take her entire family, including young children, with her. So I grew up going to Uganda several times as a young, that's me in the red tights on the equator, and then had opportunities to return to Uganda throughout my life during undergraduate and medical school, doing my MPH thesis, during residency, and then again as an attending. When I look back on some of my early global health engagements as a young adult, I cringe. Some of the interactions that I had were definitely from a position of privileged and didn't fully examine all of the imbalance that went into opportunities. But that being said, I think longitudinal involvement over decades in Uganda has also allowed me to form really strong relationships with Ugandans and do meaningful work in that setting.
So after sharing our story, we're going to spend the rest of this introduction talking about who tells the global health story. When I was living in Kenya as a hospital medicine fellow in 2015, I went to teach helping babies breathe at a remote hospital in Northwest Kenya. I found this container, which is the middle photo here, of sort of rotting, expired medical supplies. So it was a giant shipping container of the supplies on the lawn of the hospital where I was doing the training. And I took a tour, and it was filled with surgical subspecialty urology and ophthalmology kits that were not able to be used at the hospital where it was delivered to. And when I was standing in this really hot container, I thought about the people that had packed the container and the people that had donated the equipment. And I thought about how they were probably most likely white health professionals in the United States. And I wondered why they were deciding what was needed at this hospital in Kenya. And then I also wondered about the kind of affirmation and credit, even tax credit, that the packers and donators had gotten for participating in that. And I wondered about how different I was from them as an academic fellow, the credit and praise that I was getting for the research I was doing and the clinical work. And, how different was I than, these folks that ended up with good intentions donating the supplies that ended up sort of rotting in the East African sun. I really like this account on Instagram because it shows many of the ways that global health stories are told, but without exploiting colleagues or children in the process. So this is Barbie Savior, and I recommend checking it out. I want you to think about these photos, and I want you to think about how colleagues or partners might think about these photos and the stories that they might tell versus the stories that we might tell as North Americans. And I also want you to think about this phrase, Africa has its own story, and you can insert whatever your primary partner site or location is, but think about how the stories that you have experienced in global health may be different from the perspective of your partners. When we specifically think about academics, this is a qualitative study at a Ugandan university asking what it was like to have North American visitors in their health facility. I'm going to share some quotes. They see Africa as a museum of disease. They come here because of the lax of our laws. I've heard that students that come here can afford to, unlike ours. I was thinking that if the universities can offer for our students accommodation and learning opportunities for those that cannot afford, they can make the learning process more symbiotic on research. We're not a part of the design, the writing, and most of the time, we don't even hear about the results. Another lens to think about the global health story is in the history of global health and the ever-changing name of our field. As I read each of the different names of our field over time, I want you to look at the pictures and reflect again on whose story we're telling. Colonial medicine, missionary medicine, tropical medicine, international health, and our current iteration, global health. It may change soon though. We don't have to go on a plane in order to be able to see many of the themes of GHEARD. The history of medicine and public health in the United States has many striking examples, and many of these challenging chapters of our history still impact child and really general health disparities. So Flint, the southern border, police violence against Black bodies, Manifest Destiny, the Trail of Tears, boarding schools, numerous research abuses throughout our history. Dr. Hack.
Yes, and so all of this was, of course, against the backdrop of phenomena that were happening across the globe in terms of a reckoning and calling for quote unquote decolonization of the field of global health. Over the past couple of years, there's been a number of opinion pieces published in the lay media about kind of unpacking the colonial legacy of global health and global aid development. And the Black Lives Matter movement that was born out of the US also interacted with these calls and kind of added some weight to this call for reckoning of foreign aid and international NGOs and thinking about anti-racism in the global health and global development space. Next slide. You can see the graph on the left-hand side in the red box shows the search the last couple of years. There's been an explosion of pieces, mostly perspective pieces, kind of just calling for a rethinking of the way that we do global health and calling for decolonization. Next slide. So those were just a few of the examples of different articles that have come out over the past couple of years. I'll encourage you to check them out later. You can go to the next. And as Dr. Rule was alluding to, the COVID pandemic happening on top of this layered and repeated racial justice and trauma, particularly affecting Black communities within the US, and the way that COVID both uncovered and magnified existing disparities in the US, also added weight to this need to urgently address anti-racism as a public health problem, both at home and abroad in our global health work. Next slide. This also feeds in nicely to efforts within the field of pediatrics, which many of us are pediatricians who've been involved in the development of GHEARD. And within the pediatric program directors, for example, there's been a call to dismantle racism and tackle anti-racism in pediatric training curricula. Next slide. And all of this is kind of in the context of this huge demand for global health experiences from trainees from the United States. So in PEDS, over half of our pediatric residency programs offer some sort of international elective. And these opportunities do offer, the powerful and potentially transformative engagements, but also perpetuating power imbalances and colonialist tendencies if we don't really unpack these things before we're sending trainees over. So we're kind of in a natural pause right now for a lot of global health international travel because of the pandemic. So it's a good opportunity to pause and think about opportunities to re-examine the ways that our trainees engage in global health. Next slide. So I think the key question for global health education is how can we transform global health education to make explicit training around topics of global health equity, anti-racism, and decolonization? How do we promote global health engagement and partnership? And how do we center the voices of our partners? So one of the reasons we chose the acronym GHEARD is because it's really about hearing and centering the voices of our partners. And those are the voices that often are not prioritized in global health partnerships and engagements. Next slide. So it was in this that GHEARD was born. Dr. Rule and I, a few years ago at the APPD conference, were having some discussions around this. And then kind of as these events that I've just described unfolded, we quickly got together a curriculum work group and started working on this. So the curriculum was born out of a mainly pediatric focused work group, but we think it's going to be applicable across disciplines and even in other health professional settings. And as well as not just for trainees, but also for practicing clinicians who are engaging in global health.
So what is GHEARD? As we said, global health education designed for a variety of learners, and we already think it'll be expanded at least into medicine and emergency medicine. Equity, it's reflecting on equitable engagement and bidirectional partnership locally and globally. Anti-racism, it's reflecting on power and privilege and systemic injustice in the global health space while committing to a more anti-racist future. And it's decolonization, reflecting and understanding the history of global health and academics in general so that we can reimagine a more equitable and bidirectional future for our field. So one of the most, really, I think the biggest privilege that Heather and I have experienced through our GHEARD creation experience has been just the amazing team of people. So we have over 30 contributors that represent 18 institutions and the American Academy of Pediatrics, and then also represent 5 nations and 3 sovereign indigenous nations.